been a delight to be here. So I'm going to talk about traumatic cataract. And there are lots of things you have to do with traumatic cataract and trauma generally, but the most important thing is really to assess the rest of the patient. Associated injuries are really important. Then the principle is you save the eye and don't worry about the visual acuity. Always remove foreign body if you can to prevent infection. And close the eye and make it safe, and you can do lots after a couple of weeks. And nowadays with steroids, I think every patient should have steroids after trauma surgery, and surgery itself is trauma by appointment, so steroids after surgery is really important. And then just this principle that something that looks complex is really just a lot of simple steps put together. So if you can take each simple step and put them together, you can deal with a complex situation much more readily. Now, associated injuries are really important. This was a picture I'm going to show you in a minute, was a patient I saw. I got a telephone call at home from my resident. I just got home, I just put the kettle on for a nice cup of tea, and I got a telephone call saying, I've got a patient who's had a car crash and they've got a terrible laceration of their cornea. Can you come and have a look? So I drove back to the hospital, and this is what I saw. And indeed, the patient did have a terrible laceration of her cornea, but there were some other things that were going on that were a bit more important. And so the associated injuries are really the critical thing. Make sure the rest of the patient is going to survive and the airway is good and they're breathing and the heart's going and all that sort of thing. So it's just a good principle to stick by. And we had a conversation. So the other thing just to mention, enucleation for sympathetic endophthalmitis, we used to say if you don't enucleate an eye within 2 days or 10 days, then they're going to get sympathetic and there's a big problem. To be quite honest, nowadays, you should never enucleate an eye at the primary sitting. You should always try and save the eye, because with modern microsurgical techniques and steroids and anti-inflammatories and antibiotics, most eyes can be saved, and sympathetic is very rare. You can see it. This is an eye with sympathetic ophthalmia, Darlan-Fuchs nodules in the fundus, and it happens, but even if it happens, it can often be controlled with systemic medication. So as a principle, I would never enucleate an eye at the first sitting. It's a really important principle. So here's a typical traumatic cataract. This one has been sewn together a couple of weeks ago. Unfortunately, the stitching isn't quite so good, and so there's a bit of a leak there. And you have to spend your time assessing these patients. B-scan is important. Make sure they've had an X-ray of the orbit to make sure there's no metal foreign body that's gone through. And essentially, again, taking things step by step and making a complex situation simple is important. So the principle or the purpose of showing this one is that this cataract is soft and fluffy and easy to aspirate out with a Simcoe cannula. But it's really to make the point that you can use Vision Blue at any point during the operation. If you're halfway through the rhexis, or if you're not sure what's happening with the capsule, you can put Vision Blue in and you can ascertain what's going on with the capsule much more easily. And you'll see here that eventually the capsular rhexis is completed because the Vision Blue makes it much more visible. So don't be afraid to stop, use Vision Blue, make sure you're reassessing the situation as you go along, and it gives you a much more controlled environment and you can see what you're doing. And of course, once the cataract's out and the implant's in, you have to restitch the cornea because you don't want it to leak. So your microsurgical skills have to be up to par, and you have to be able to tie a good reef knot, make sure it's watertight, and obey all the principles of tying a knot that give you the tension that you want and the correct, the least astigmatism. And what's interesting about these eyes is although that's got a fairly central corneal scar now, when that settles down and you've taken the stitches out, with a contact lens, that patient can often achieve 612, 6.9. They do really well. What looks terrible initially can do very well. And that's a principle I'm going to stick with all the way through. So again, here's a complex situation. What do you do first? Do you do the iris repair first, or do you do the cataract first? And you can do either. There are proponents for doing either. What I did here was to create some scleral flaps, use the viscoelastic as a soft tool. You don't want to really touch the iris if you can help it. It's a very delicate tissue. The least manipulation of the iris for all surgery is really important. You have to touch it to get a needle through. This is a really handy instrument here, this little micro manipulator ring, and it helps you to put the needle through the iris with some counter traction, and just to speed things up because it takes a while to do this. Once the iris is sutured in 2 or 3 places, you've now got a nice, almost normal-looking eye, and you can do a straightforward cataract procedure. So again, simple steps to get you to a situation where you are in familiar territory, and this eye ended up with a reasonable sized pupil, and effectively peripheral iridectomies at the top where the iris wasn't sutured, and the patient did quite well. Here's an interesting one. This is a case that a registrar brought me to the clinic. He said, this patient was having an Ozurdex injection and I slipped. And this is the Ozurdex drug. There aren't many people that have seen that. But this is the Ozurdex rod, which costs 3,000 British pounds, which nowadays are pretty worthless, but in those days it was expensive. And so 2 things, what do you do? Because I'd never seen this before. This was unique for me as well. What do you do about the Ozurdex? This patient was having Ozurdex because they had a retinal vein occlusion. And at £3,000 a shot, I wasn't going to throw it in the dustbin. So what do? Well, you make it up as you go along. You try and do the best you can and prepare yourself for the surgery. In effect, this was pretty straightforward. I did put an iris hook in there because that's the site there where the injection was made, and I thought there might be a zonular weakness because this had clearly gone through the edge of the lens. But eventually it came out relatively easily with phaco. We took the rod out of the eye and then completed the phaco. There wasn't any zonular weakness as it turned out. Implant went in, and then you had to decide, well, this patient still needs an Ozurdex injection. I'm not going to do another one. So we saved the piece of Ozurdex and put it back into the eye. I had to do a posterior capsulorhexis and put the Ozurdex into the vitreous cavity where it started in the first place, or where it should have been in the first place. And I pointed out to the registrar that was a much quicker way of doing it. If they just injected it into the back of the eye first, we wouldn't have had to go through all this. But again, just the principles are think things through, make sure you've got the right apparatus, take things slowly, and do simple steps that get you into a situation which you're familiar with. So there the Ozurdex is going back into the eye, and the patient, again, did reasonably well and got reasonable vision after their vein occlusion was treated. This looks dreadful. So this is a young child who was fighting with his brother, playing sword fighting, and with twigs in the garden. And the twig, unfortunately, went into his eye, and it looks like a flake chocolate, I think. But anyway, at this point, the mother and father were saying, will he need new glasses, and what's the problem? What's the prognosis going to be? And I'd never seen this before. This was fairly firmly stuck. I didn't know where it went. We couldn't X-ray or scan this child because he was screaming. And we just had to anesthetize him and take this out. And then you have to think of things like, we've got to send this to the lab, because I don't know what grows on sticks in the garden, but I'm sure they're bugs that you don't normally come across in everyday life. So remember to send that to the microbiology lab. And then basic principles: stop any bleeding, close the eye, make it safe, make sure your stitching is up to par, practice it, get the eye safe and closed. The eye was full of blood. Again, I didn't know where the stick had ended up. I didn't know what the retina was like. And so once the eye is closed, you can give a lot of steroids, a lot of antibiotic. And this is about 3 months later. This was in the days before Vision Blue. So we took him back to theatre to take out his cataract. As it turned out, the stick had gone beside the lens, but hadn't really damaged the retina at all. And with a lot of persistence and perseverance, we managed to get the capsule open and the cataract out and a 3-piece lens in the bag. And again, with a contact lens, this child got 6/9 vision. So what initially looks terrible with a piece of wood sticking out of the eye, and you think, well, this eye's for the bucket, can do very well. And you just take things slowly and in stages. Now, as I said to you, I'd never seen anything like that before, and I showed this to my wife, who is a doctor, and she's an A&E consultant, so she was used to dealing with emergencies. I said, I'd never seen a piece of wood that big in someone's eye. She said, oh, how about this? And I said, well, that's not wood, it's bamboo. She said, okay, how about this then? And I admitted that I'd lost the competition then for the biggest piece of wood, and I don't compete with her anymore. And that was the outcome for that child. The eye settled down very well. He got about 6/9 vision, and the scar settled, and he did very well. So again, as I say, what looks initially like it might end up with a very poor prognosis, if it's treated well and done in stages, can get a very good outcome. But you must be prepared when you're doing this surgery to do anything. You've got to be able to take extraocular muscles off, explore the globe, suture it up, put the muscles back on. send things for culture. Just think outside the box. Make sure you have a lot of equipment. I'm quite famous in my theatre for using all the equipment I possibly can. I just enjoy it. But it is important. Don't put up with not using equipment just because it's the middle of the night or it's late or whatever. So make sure appropriate instrumentation is used. So you do need experience to manage trauma. You've got to get a good history, a rapid and complete assessment and investigation of the injury itself, but also the associated injuries. Make sure you get rapid access to theatre. You don't want a child like that waiting 4 hours or overnight. You've got to get on with it quickly and be prepared to do anything. Really important. Thank you very much.